Welcome to IACI TV. I've been joined by Killian Eyerich from the Technical University of Munich in Germany, and our topic today is new treatment strategies for atopic dermatitis. But you work in experimental dermatoimmunology. Before we start, can you explain what that means?
Of course, I'll try at least. That's basically a way of analyzing how the immune system affects inflammatory or autoimmune skin diseases. Primarily, dermatologists historically thought, okay, the skin is a barrier organ, right? And it took some decades to understand how actually immunologically active the skin is. But nowadays, to investigate the interaction of the immune system and skin epithelial cells basically explains a lot of chronic inflammatory diseases.
How widespread is dermatitis, and in particular atopic dermatitis?
Yeah, that's the first issue that you just mentioned. The question is dermatitis or atopic dermatitis.
So what's the difference?
The difference is that atopic dermatitis is something that is at least partially defined by, let's say, 20 different criteria and clinically defined disease, where we think we have an idea about the pathogenesis, we have treatment aims, and we have labeled and approved therapies. While dermatitis looks very similar to the expert, and it consists of at least 20, 30 different diagnoses that all in the end are looking similar, and probably pathogenetically they are similar, but they are poorly defined, they are proposed 100 years ago, and we do not really know what's the underlying pathogenesis.
I mean, just for clarity, you just said that experts don't understand. So is this the problem, that you've moved now into a level of understanding that you haven't had before, so even the experts are in the dark?
This is exactly the case. So what we now try to understand is how the immune system, the microbiome, the barrier interacts to create a chronic disease, such as atopic dermatitis. So we know a lot from there. On the other hand, we come from a historical disease ontology that is hundreds of years old. And now we try and squeeze in our molecular knowledge in this old classification, and there the problems arise even among experts.
So basically, in the past, you'd see something that you thought was a symptom, and you'd find a lotion or an ointment or something that is going to get rid of inflammation or dermatology.
Exactly. In the past, we thought, okay, this looks like this, so we call it like that, and we give some extra names behind it.
So informed guessing is basically what you're saying.
That's what we do in the clinics. If we are at congresses or if we do research, we really say this molecule interacts with that one very precisely. Then we go to our patients, and we are back to the educated guessing.
So what are the main causes of atopic dermatitis?
Well, it's like many common diseases, a complex disease. The three basic principles of atopic dermatitis or atopic eczema are barrier damage. So we lose water through the skin, and that's why we get dry skin. The microbiome, that means bacteria colonizing the skin of AD patients, are different from healthy. And the third thing is the immune system is altered, and immune cells infiltrate the skin and invade the skin. And the interaction of these three creates something that is atopic dermatitis. Now, where this starts and how they interact, that can differ amongst the patients. That's why atopic dermatitis is so heterogeneous.
So what new ways of thinking do dermatologists need to develop in order to differentiate between atopic dermatitis and dermatitis?
What we need is, we need molecular knowledge about it. So in the end, we need to understand what's molecularly driving the disease. And then, as I said, it's a very heterogeneous disease, so this will not be the same in all the patients.
All right, so therefore, the diagnosis is going to move more and more into precision medicine. So how are you going to move into that way of diagnosing and then treating patients who may have completely different symptoms or different causes of those symptoms?
Yeah, it's exactly as you say. That's where we need to approach. And that's why we have to understand more about the individual patient. So that starts at the level of the physicians. We need to better describe what we actually have in hand, and then combine that with the research. The clinical research or clinician scientist is what we need here.
So how far are we away from a world where precision medicine can accurately diagnose and then tailor a specific solution to that particular patient problem?
Something close to precision medicine is done in dermatology for always. So we check how does the skin look, how is the distribution, does it look like super infection, yes or no, and then we make a decision. But that is an educated guess, as you just said. Now to arrive to the next level, what we need is diagnostic tools. And there will be definitely 2 different diagnostic tools, but we don't have any of them yet. The one that is closer is the machine learning and apps. That means already now there are apps out there. Patients can take a picture of themselves and then they get a machine learning algorithm with a proposed diagnosis.
So they don't need dermatologists who aren't up to speed with the latest developments in the treatment?
That's not related to treatment. That's a good thing. It's not related to treatment. For that, we need something else. But for diagnosis, very soon, I'm sure that the general practitioner will be confronted with apps that may be better than their diagnostic knowledge.
So this is the worst thing for a clinician now, that it's bad enough that a patient comes in and says, I've been on the internet and I found this out about my condition. Now people are going to be bringing photographic evidence based on apps.
Yes.
Is that going to make life easier for a clinician or more difficult?
That's exactly the point. The question is about the quality, right? Because if nowadays you look in the internet yourself, like Dr. Google, what you will find is a lot of crap information.
Is that a technical expression? Crap information?
Crap information and Dr. Google, yes. And it goes together. You cannot do only one of the two. No, you understand what I mean, right?
Yeah.
You are very poorly informed. You will have a lot of wrong information. Now, if we really can create apps and machine learning and feed in good information, then that is clearly an advantage also for the physician, because what it would do in the end is it would create time that we have for the patient, like empathy, studying the diagnosis, understanding the personality of the patient that is next to me. Everything now we don't have time for. That might be created if we save time by using these algorithms.
Okay. I'm also thinking that it also creates a massive amount of potentially very useful data that can then be added to a global database that's going to help people understand this much more.
Absolutely, and there's also a risk, of course, because it needs to be data protected, and we need to understand a lot. So that's almost an ethical issue.
We haven't got enough hours in the day to be able to talk about those issues.
But what I would like to introduce also next to this machine learning is the molecular diagnostics, because that will be the next thing that we need to introduce. And that is a little more far away, but also I think next year or in 2 years we will have the first lab-on-a-chip devices where we have molecular information, and that would probably create something like, this is the best therapy for this particular patient.
Okay, so what new innovative targeted treatment strategies have been developed for atopic dermatitis in addition to what you're talking about?
At the moment, we are at the level where we understand the immunity behind atopic dermatitis at a very broad level, like the end-stream immunology. And there are specific targets, these type 2 immunity targets that have been developed. Dupilumab is the first antibody that is in label since 2 years. And there are several others coming targeting specific other aspects of type 2 immunity. So at the level of downstream, end-stream type 2 immunity, we have very precise and good novel therapies, either already approved or to come.
I mean, what I find really, really interesting is that you're talking about, the time in the future in 1 to 2 years where things are going to change massively. I mean, I remember 10, 15, 20 years ago where people would be talking, well, we might see a change in the next 5 to 10 years. It seems to be accelerating so much.
Definitely, I fully agree.
Do you find that threatening or do you find that exciting?
Yeah, there's a risk in it because maybe we'll make some mistakes. On the other hand, I think it's definitely a chance and thrilling to be a dermatologist in these times. If we just look at oncology, we can already see how probably inflammation will develop, and that is companion diagnostics, fixed algorithms, more and more therapeutic tools that we have, and we add on at a precision level for the individual patient.
Well, funnily enough, I do a lot of work with nuclear medicine, and that's exactly what's happening in that field, and it's so fast, and it's developing so quickly. Killian, thank you very much indeed. It's been fascinating to meet you. Thank you. Enjoy the rest of the Congress.
I thank you very much.
We'll be back with more from EACI TV later.